hepatic artery is giving the right gastric artery, gastroduodenal artery, and hepatic artery proper. Hepatic artery proper again divides into these two branches, right and left hepatic artery, and from right hepatic artery it gives a branch cystic artery. Okay, and this gastroduodenal artery is dividing into right gastroepiploic artery and superior pancreaticoduodenal artery. So all these arteries are involved in supplying the stomach. Next, see here the location of the arteries. See, this is the celiac trunk dividing into three trunks. This is left gastric artery lying along the lesser curvature, also giving a branch to the lower part of the esophagus. Next, this tortuous artery is splenic artery. Okay, from the splenic artery, sometimes one artery is arising, that is posterior gastric artery. Sometimes it is missed. Okay, that's why you have to know it. In case of if you don't ligate this artery during removal of the stomach or removal of part of stomach, there will be heavy bleeding because of presence of this artery. This is not present in all the individuals. And this is splenic artery going towards the spleen, and it is giving short gastric arteries. Short gastric arteries are supplying the fundus of the stomach, and this is left gastroepiploic artery lying along the greater curvature of the stomach. Next, this one is common hepatic artery. Common hepatic artery giving the right gastric artery lying along the lesser curvatures of stomach. Common hepatic artery proper, which is going towards the liver, and it will divide into right and left hepatic artery. Right hepatic artery again give the cystic artery, and this is gastroduodenal artery. From the gastroduodenal, this is supraduodenal, and gastroduodenal divides into superior pancreaticoduodenal and the right gastroepiploic. Right gastroepiploic lying along the greater curvature of the stomach, supplying the stomach and also the greater omentum. Okay, so these are the arteries, position of different arteries. So we'll discuss the individual arteries. So left gastric artery, there are multiple variations regarding the origin of this artery. Most common thing we will discuss mainly. Okay, most common thing you have to remember. So left gastric artery, in 90% cases, it arises from the celiac axis or celiac trunk. 4% it arises from gastrosplenic trunk. 3% directly originate from aorta, and 2% it is hepatogastric trunk. So here is the left gastric artery, the bluish colored one here. Branches, it has anterior and posterior branch before entering the lesser curvature of the stomach. Okay, next is right gastric artery. Okay, so this one is right gastric artery, branch from common hepatic, and in it is a branch from proper hepatic artery in case of 50 to 68% cases, from left hepatic artery in 29 to 40% cases, from common hepatic artery in 3% cases, and other less frequent sources are also present. Next, we go to gastroduodenal artery. It arises from the common hepatic artery, which is branch of celiac trunk, and splanchnic artery aneurysm of gastroduodenal artery are very rare. This is a clinical condition and are often missed preoperatively. Okay, aneurysm means there will be high chance of bleeding. Next, right gastroepiploic artery, branch of it is a branch of gastroduodenal artery. This one is right gastroepiploic artery, and occasionally it arises from superior mesenteric artery or anterior superior pancreaticoduodenal artery. Okay, so what is the surgical importance for omental viability during distal gastrectomy? The right gastroepiploic artery should be preserved by one of these following methods. You have to ligate its gastric branches or ligating the anterior epiploic branches. These epiploic branches means they are supplying the greater omentum. Okay, and ligating the right epiploic distal and close to the origin of the right epiploic artery. So these are the methods how you preserve the blood supply towards the momentum. Next is left gastroepiploic artery. 26% cases it arises from splenic artery. In 66% from splenic artery by a common stem with inferior polar splenic branch. And it is the largest branch of the splenic artery, this left gastroepiploic. With branches of right gastroepiploic, they form a arc of Barklow. Okay, arc of Barklow is formed along the greater curvature of the stomach. See here, this is the arc of Barklow along the greater curvature of the stomach. And these are the epiploic arteries. Right epiploic arteries, these are anterior epiploic artery, these are posterior epiploic artery, which is shaded line. Okay. Left epiploic artery, like this, these epiploic arteries are supplying the greater momentum, lying over the gut. Next. What is the surgical importance? In splenectomy, ligation of the splenic artery and vein should be located distal to the origin of left gastroepiploic vessels, and the splenic vessels should be ligated very close to their entrance into the spleen to avoid the postoperative bleeding, which follows the ligation proximal to the origin of left gastroepiploic artery. There will be bleeding through this artery because there is blood is coming through the anastomosis along with the right gastroepiploic artery. So we have to ligate the artery distal to the origin of this gastroepiploic artery. Okay, next. Next, we go to short gastric arteries. These are the short gastric arteries. They arise from splenic or left gastroepiploic artery and supply the fundus and upper part of the body of the stomach. These shorter vessels are the troublemaker in splenectomy, and careful ligation is done. An imbrication of greater curvature is a safety measure to avoid the bleeding or possible necrosis with perforation. Okay, imbrication means overlapping of the greater momentum is greater curvature is done. Next, next is posterior gastric artery. Okay, it is a important for your viva also. Sometimes in your stomach viscera, you will must be asked about this blood supply in your viscera table. Okay, stomach is important viscera. So read the blood supply very carefully, and if you can completely tell the blood supply, you will also be asked about this artery, posterior gastric artery. Okay, where it lies and what is the surgical importance. So, posterior gastric artery, proximal, middle, or distal segment of the splenic artery, it arises. Inadvertent ligation or division of the artery can cause complications including focal necrosis and postoperative hemorrhage. The posterior gastric artery has also been referred to as the accessory left gastric artery or ascending posterior esophagogastric artery. Okay. So this one is posterior gastric artery arising from the splenic artery. And this is the cervical surgical importance. There is chance of postoperative hemorrhage. Next, arteries of distal esophagus and proximal stomach. Inferior phrenic artery supplies the margin of the hiatus. See, this one is inferior phrenic artery. This is direct branch from abdominal aorta just after it enters the abdomen, passing through the esophageal opening. Okay, passing through the aortic opening. So, and this is esophageal opening, through it passing the esophagus, and esophagus being continuous with the stomach. So, inferior phrenic artery supplies the margin of the hiatus. Esophageal branch of left gastric artery supplies the distal esophagus and passes through the hiatus to anastomose with the thoracic esophageal arteries. Okay, so this is the supply of distal esophagus and proximal stomach. Next, so these are the branches. Schematic representation: celiac trunk, from celiac trunk left gastric artery splenic artery, and common hepatic. Common hepatic is giving hepatic artery proper, gastroduodenal, right gastric. This one is superior pancreas, gastroduodenal dividing into superior pancreaticoduodenal, right gastroepiploic, and splenic artery is giving splenic branches, short gastric, left gastroepiploic. Okay, so this is the blood's arterial supply of the stomach. Next, so and at microscopic level, okay, microscopic level, the blood supply, arterial circulation of the gastric wall and surgical importance, each of the smaller branches of major arteries, they perforate the musculature of the stomach and supply the some mucosal plexus, and mucosa of the lesser curvature is supplied by small extrinsic branches of left and right gastric arteries rather than by vessels from the submucosal plexus. And ligation of extrinsic arteries will not control bleeding from the gastric ulcer. The stomach remains viable after ligation of all arteries except the right gastroepiploic artery and the right gastric artery. Okay. Next, with subtotal gastrectomy, the gastric remnant remains viable with circulation from the left gastroepiploic artery and the short gastric artery because the left gastric artery is ligated. And with 90 to 95% gastrectomy, the remnant stays alive and well because of the descending esophageal arteries. The blood supply of proximal gastric pouch depends on these three sources: ascending branch of left gastric, short gastric, posterior gastric if present. And adhesions of the posterior gastric wall must not be cut, as such adhesion may contain the posterior gastric artery. Okay, that's how you preserve the posterior gastric artery. Next, so we have completed the arterial supply of the stomach. Okay. Next we go to venous drainage of stomach. So you always remember blood supply means you have to write down both arterial supply and venous drainage. Blood supply of stomach is important long question for theory, also very frequently asked in your viva table. Okay, for stomach viscera. And which artery is branch of which artery, these things also comes in your OSPI or in your MCQs. Okay, that's why you remember and you practice a schematic diagram, okay, for arterial supply. So venous drainage is parallel to the arterial supply. Right and left gastric veins drain to the portal vein. Right gastroepiploic vein drains to the superior mesenteric vein. Left gastroepiploic vein drains to the splenic vein. Next, see here, left and right gastric veins, they are draining to this portal vein. Okay, and this is superior mesenteric vein and this is splenic vein. Superior mesenteric vein and splenic vein were joining to form the portal vein. And you can see here this left gastroepiploic artery is draining into the splenic vein. Right gastroepiploic artery is draining into superior mesenteric vein. Short gastric veins are also draining into the splenic vein, like the arteries, branches of arteries. Next. So, bleeding from severed distal branches of the left gastric vein can be profuse because of anastomosis within the left gastric, esophageal, and hemiazygous veins. Okay, there is the anastomosis, left gastric vein along with the hemiazygous vein. Okay, next. Right gastric vein, it travels with the right gastric artery. This one is right gastric vein. And the prepyloric vein of Mayo is a tributary of the right gastric vein. This one. Okay, prepyloric vein of Mayo. This is an important surgical structure. It helps in identifying the pyloric end of the stomach. Okay, prepyloric vein of Mayo. So, this is a tributary of the right gastric vein. Next. So major variations, there is also variation in arterial supply, also variations in venous drainage. So the inferior mesenteric vein enters the splenic vein in 30% case, inferior mesenteric vein enters superior mesenteric vein in 30% cases, and it enters the splenomesenteric junction in 30% cases. And right gastric vein enters the upper portal vein in 30%, in lower portal in 30%, at the junction between upper and lower portal in 30%, and left gastric vein enter the upper portal in 30%, all are 30%. In the lower portal in 30% and enters the splenic vein in 30% cases. So there are major variations in venous drainage. Okay, you just remember like the as the branches of arteries, the veins are lying, and you remember they are draining also like that. Okay, there is chance of variation. You remember that point. Next, so right gastroepiploic vein, it empties into the superior mesenteric vein in most of the cases. And gastrocolic vein, it is known as Henle's gastrocolic trunk. It is present in 70% of the cases, and it is formed by confluence of gastroepiploic vein and right upper colic vein. The gastrocolic vein is short and is located beneath the root of the transverse mesocolon and traveling along the anterior surface of head of the pancreas. Okay. Next. Next is left gastroepiploic vein. Here is the left gastroepiploic vein. It drains into the splenic vein or into one of its terminal, and ligation should be placed as close as possible to the hilum of the spleen. Okay, next. Short gastric veins drain into the splenic vein. These are the short gastric vein draining into the splenic vein. And see here the formation of portal vein. Splenic vein joins with the superior mesenteric vein to form the portal vein. Okay, and this left and right gastric veins are draining into this portal vein. This inferior mesenteric vein generally drains into this splenic vein. Short gastric vein and left gastroepiploic veins are also draining into splenic vein, and this right gastroepiploic vein draining into superior mesenteric vein. So for venous drainage, you practice this diagram. Okay, venous drainage of stomach. So also these veins may empty directly into the upper part of the spleen. Short gastric vessels should be ligated carefully and they retract easily, and together with the left gastroepiploic vein can be associated with post-operative bleeding. Okay, next. So this is schematic presentation of venous drainage. Left gastric and esophageal branches, they are draining into portal vein. Right gastric also draining into portal vein. Okay, superior pancreatico-duodenal is also draining into portal vein. And this right gastroepiploic draining into superior mesenteric vein, left gastroepiploic, short gastric, these are draining into splenic vein. And splenic vein and superior mesenteric vein, they are joining to form the portal vein. Okay, and the prepyloric vein of Mayo, what was first described by Laterjet. Okay, there are nerves of Laterjet in your nerves. During discussion of nerve supply of stomach, you will see nerves of Laterjet. In these are branches of vagus nerve, anterior and posterior trunk of vagus are there, and from there branches are supplying the stomach. So in selective selective cutting of those vagal branches, you have to cut those nerves of Laterjet. Okay, we will discuss later during stomach class. Next. So we have completed the venous drainage. So blood supply is complete. You prepare as a long question, blood supply. Prepare two schematic diagram, one for arterial supply, one for venous drainage, and prepare a long note regarding the arterial supply and venous drainage. Next, we go to lymphatic drainage of stomach. For lymphatic drainage, we have divided the stomach into four zones. Okay, zone 1, 2, 3, and 4. Okay, so the four zones are zone 1. This one is zone 1. Zone 1 is inferior gastric, Zone 2 is splenic, and Zone 3 is superior gastric, and Zone 4 is hepatic. According to their drainage of lymph, these zones have been names have been given. Next, and these arrows indicate the drainage direction of drainage of lymph find its way to the celiac nodes. Okay, so this splenic node drains into splenic node. These are draining into right gastroepiploic node, then going to the celiac nodes, and here it is draining into left gastric nodes. Here they are going towards the hepatic nodes, and ultimately all these nodes are going to drain into the celiac nodes. Okay, next, so this is these zones are named differently here, area 1, 2, 3, 4, like this. So this stomach is dividing into right two third and left one third. So this is right two third and this is left one third. Right two third is again divided into upper two third, that is area 1, and this lower one third is area 4. So upper two third is left gastric area. Here is lying the left gastric artery. So these nodes are lying along the artery. That's why the name is given left gastric artery, which is again draining into celiac nodes. Then left one third, this is area 4. This is right gastric zone. Okay, so right gastric zone is draining into right gastric node, again going to the celiac nodes. Next we go to left one third. This part is left one third. It is again divided into upper one third. This one is upper one third, area 3, that is pancreatico-splenic nodes. They are going to pancreatico-splenic nodes. And lower two third, this one is lower two third. This is area 2. This is right gastroepiploic and pyloric nodes. Okay, right gastroepiploic and pyloric nodes, they are again going towards the hepatic nodes lying along the common hepatic and hepatic artery proper, and from these nodes to the celiac nodes. Okay, so ultimately almost all the lymphs are going towards the celiac nodes. Okay, next. So the lymphatics from the stomach follow four territories. The areas of drainage are divided as follows. It is divided into right two third and left one third by its long axis, and each of these areas is divided into upper and lower areas. Area 1, it is the upper two third of right two third of the stomach, and it is the largest area, lies along the lesser curvatures, drains into left gastric nodes. Area 2 is the lower two third part of the left one third of the stomach, and it lies along pyloric antrum and pyloric canal along the greater curvature of stomach, and it drains into right gastroepiploic nodes and pyloric nodes, and it is the most common site of gastric carcinoma. Okay, so carcinoma spreads through the lymphatics. That's why you have to know the lymph nodes where it is draining. Okay, and that lymph node will be enlarged in case of involvement of the cancer. And during removal of the cancerous tissue, also have to remove the lymph nodes. Okay. Area 3 is pancreatico-splenic area. It is upper one third of left one third area of the stomach. It drains into pancreatico-splenic nodes. And area 4, it is the lower third of the right two third of the stomach. It includes the pyloric antrum and pyloric canal along the lesser curvature of stomach, and it drains into right gastric and hepatic nodes. All are finally drained into celiac nodes. Okay, next. Wait, this is the flow chart. Right two third, left one third. Right two third, upper two third, area 1, left gastric node. Lower one third, area 4, right gastric and hepatic nodes. Left one third, upper one third is pancreatico-splenic node, area 3. Lower two third, area 2, right gastroepiploic node. So this is the draining areas. Next. Okay, so entire stomach is going towards the celiac nodes. Right two third, area 1, upper two third is left gastric node, area 4, lower one third right gastric and hepatic node, and area 3, upper one third that is left one third of stomach, pancreaticosplenic, and area 2 lower two third right gastroepiploic nodes. Next. So left gastric lymph nodes, they drain areas of both anterior and posterior gastric walls, and pancreaticosplenic nodes drain the gastric fundus and body, and right gastroepiploic nodes drain the right half of the greater curvature, occasionally include the pylorus, and hepatic pyloric from hepatic nodes it goes to pyloric node. Left gastric nodes drain the pyloric part of the stomach. Okay. Next. So these are the 8 groups of lymph nodes of the stomach. 8 important groups. There are paracardiac nodes. Paracardiac nodes means they are lying around the cardiac end of the stomach. Left gastric nodes at the left along the left gastric artery. Celiac nodes at the celiac artery near the celiac artery, celiac trunk. Suprapyloric nodes above the pyloric end. Infrapyloric node below the pyloric end. Right gastroepiploic node at the pathway of right gastroepiploic artery. Pancreaticosplenic node at the pathway of left gastroepiploic artery, and upper greater curvature nodes at the short gastric vessels. Okay. Next, these are the different nodes. Okay, here is the paracardiac nodes near the cardiac end, left gastric nodes. Okay, this is celiac node along the celiac trunk. This is suprapyloric node, infrapyloric node, right gastroepiploic node. Here is the pancreaticosplenic node, short gastric nodes. Okay, important group of lymph nodes. Next, there are different numbering system. Okay, for gastric cancer, during removal of the cancerous area you have to also remove the draining lymph nodes. Okay, because cancer will not be removed if you don't remove the lymph nodes, and there will be recurrence, high chance of recurrence. So, the anatomical, this is classification of nodal stations in gastric cancer. Japanese Gastric Cancer Association did this nomenclature. So, anatomical definition of lymph nodes and their locations. Regional lymph nodes of stomach are classified into station number from 1 to 20. These stations are important also in your surgery. Okay, in surgery it is mainly important, plus stations numbered 110, 11 and 112 is there. So lymph node station 1 to 12 and 14V, they are regional stations, and other lymph node locations are distant stations. Metastasis is represented as M1. Okay, first line of metastatic lymph node. And lymph node number 16, 19, 10, 100, 10, 11, these regional lymph node are involved in case of direct invasion of esophagus by the tumor. And lymph node metastasis is classified as 1. NX means regional lymph nodes cannot be assessed. N0 means no regional lymph node metastasis. N1 is 1 to 2 regional lymph node metastasis. These are regional lymph nodes. We have discussed 1 to 12 and 14V. And N2 means 3 to 6 regional lymph nodes metastasis have occurred. N3 is 7 or more regional lymph node metastasis. N3 is again divided into N3A and N3B. N3A is 7 to 15 regional lymph node metastasis, and N3B is more than 15 regional lymph nodes metastasis. That means all the lymph nodes are involved. Next, these are the stations. Okay, you generally remember for lymphatic drainage the 4 areas and their drainage, and all are going to celiac trunk. That part is very important, and if you can remember this station 1 to 20 station is important. Okay, and if you cannot remember those stations, the 7 zones, 7 lymph nodes, 7 regional lymph nodes I have discussed previously, that is important for your surgical aspects. So see grossly, 1 is right paracardiac lymph node, include all those along the first branch of ascending limb of left gastric. 2 is left paracardiac, 3 is Lesser curvature nodes along branch of left gastric. 3B is lesser curvature node along second branch and distal part of right gastric. 4SA, 4SB and 4D are there along the greater curvature. 5, 6 and 5 is suprapyloric, 6 is infrapyloric, 7 is lymph node along the trunk of left gastric between its root and origin of ascending branch. 8A and 8B, 8A is anterosuperior nodes along common hepatic, 8B is posterior lymph nodes along common hepatic. 9 is celiac, artery celiac nodes, 10 is splenic hilum lymph nodes, 11 P and D. 11 proximal and distal. P and D represents proximal distal. Proximal splenic artery lymph node, distal splenic artery nodes. 12 is hepatoduodenal ligament lymph nodes. Okay, next. 13 is lymph node on posterior surface of pancreatic head, cranial to duodenal papilla. 14 V is lymph node along the superior mesenteric vein. 15 is along the middle colic vessels. 16 A1, A2 and B1, B2 is there. A1, A2 is para-aortic nodes. B1, B2 is para-aortic nodes. Between their regions are different. Upper border of left renal vein, here is upper border of origin of inferior mesenteric artery aortic bifurcation. Second, lymph node on the anterior surface of pancreatic head beneath the pancreatic sheath. 18 is lymph node along inferior border of pancreatic body. 19 is infradiaphragmatic node predominantly along the subphrenic artery. 20 is paraesophageal nodes. 110 is paraesophageal nodes in the lower thorax. 111 is supradiaphragmatic nodes separate from the esophagus, and 112 is posterior mediastinal lymph nodes separate from the esophagus and esophageal habitus. And you can see here 100 up to 20 they are located within the abdominal cavity, okay, and 110, 11, 12 they are located in the thorax, okay. That's why the numbering is different here. Okay, so if possible, you can remember it. It is important for your surgeries. And for lymphatic drainage is also can also come as a short note, or it can come as a part of the long question. You prepare as those four areas. Divide the stomach as four areas and their drainage. Okay, that is important. You must write for lymphatic drainage. Okay, at clinical aspect, you there is high chance of cancer spread, so that's why you have to remember